This is the Psychobiology, Psychopharmacology, Chapter 3, Part 2. Now we're going to start getting in the medications. As we go through each grouping, pause yourself, take a break, and then go into the next section. Okay? I also want to make sure that you go into each chapter grouping, whether we're talking about anti-anxieties, antidepressants, antipsychotics, go to the chapter that correlates with those topics and look over the patient teachings. So in this section, as I'm discussing it, make sure you can connect the psychotropic drug that the neurotransmitter is going to be impacted. So if it's depression, it's primarily serotonin. Then we may pull on norepinephrine or dopamine. And then also, if we're looking at, then since we're impacting those things, what are going to be the side effects? So then what are going to be the patient teachings that we need to talk about with the patient? And so if we're giving an antidepressant, what would we expect to happen? We would see an improvement in the depression, a lifting of the depression. If we're giving an anti-anxiety, then we would expect a lessening of anxiety, correct? If we've got an antipsychotic going on, then we would see an improvement in where the patient would be reality testing or being able to function more in taking self-care activities. So whatever the symptomology the patient is presenting with that we're treating with the medication, we would see a noticeable improvement of whatever the deficit is. So that is what we're doing, simple components. So we're going to look at the functions of the brain and how psychotropic medications, otherwise also known as neuroleptic medications, alter the functions of the brain and address mental disorders such as depression, anxiety. We're going to discuss the neurotransmitters and the chemical messengers of the brain and how this addresses mental disorders. And we're also going to discuss imaging techniques and how they're used to address the brain. Also, I want to enforce and reinforce with you to look at your patient teaching tools that start in Chapter 11 through Chapter 24 because you're going to need to know what to teach your patients. So when we talk about psychotropic medications or neuroleptic medications, there's an overall concept you need to be thinking about. Since we're talking about the central nervous system, we're talking about the brain, this means it's going to affect brain function. Whether it's mild, moderate, or severe in functioning, it's going to somewhat function and affect the brain. So common sense things that you need to think about with telling your patient, whether it's an antidepressant or an antipsychotic medication or an anti-anxiety medication or a attention deficit medication that's a stimulant, or even if it's a herbal medication such as St. John's wort, which is an antidepressant, or GABA, or melatonin, these all are going to affect the brain. So what do you think you would need to tell somebody? Don't operate heavy machinery. So let's not drive a car right away till you know how it's going to affect you. How about let's not make any major life decisions or changes for the next couple weeks till you know how it's going to affect you? How about maybe you're going to feel a little foggy? Don't fight it, go with it. Because if you're going to fight it, you might not get the best benefit, right? Because you're going to, if it's supposed to be an anti-anxiety and you're fighting against it and it's supposed to help you relax, but you're not letting it help you relax, then why are you taking it? Doesn't make quite sense, does it? How about the fact that if you're going to get a headache from it because you're fighting it, you might have a little bit of blurred vision. It may recover, but it may be there for a little bit. These are just some things that might occur that are just some things that are because it's affecting your brain. What about your ability to concentrate? So these are things you need to let your patient know are possibilities that are going to happen. And this is without even knowing what drug the person's getting. These are things that are going to just occur, okay? So let's get into this chapter a little bit more. And what okay, so benzodiazepines, page 49. So you also want to go and look in chapter 15. I think it starts on page 270. I want you to look at all the patient education components that are there. So with benzos, note that they end in PAM and LAM. They target the GABA in the central nervous system. So that's what we're going to increase in is the GABA to help relax this person. The person's taking, and it's going to couple with calcium and potassium. So if they're also taking any medications that produce or push calcium and potassium, we're going to enhance the effect of this medication and cause even further sedation and further relaxation. It's going to impact pain, memory, and mood. So the person's not going to this may, which word I'm going to use? It's going to not necessarily be good that it impacts memory or pain or mood, because they may have a negative effect. They may not recognize that they've hurt themselves. They may not remember something. Their mood could be irritable, or it could be I don't care. Could make them what? So you have to be very conscious about this. This is a benzodiazepine. So what about benzos, you guys? They're addictive. They're meant to be given for a short period of time, 3 months. On a regular basis, 3 months. Because they're addictive. They're going to develop a dependency. Along with alcohol, benzos is the other high-risk drug. If you become physically dependent upon them, if you just abruptly stop, you're at risk of developing seizures. You have to actually end up being in a hospital to detox off of these for great risk of having seizures. So we have to be very conscious about this, be very careful watching this. These can drop blood pressures. You don't mix drugs and opiates and alcohol with them. Why? Because it decreases the CNS. It depresses the CNS system, that depresses the respiratory system. This is a sentinel alert that is put out by the Joint Commissions that regulates a lot of the hospitals. And so they watch, they look, and this is one of the things that you'll find that you'll have is when you'll get an alert at the hospital if you have a patient that is prescribed both an opiate and a benzo at the same time, because you shouldn't be giving both to the patient at the same time or be prescribed at the same time. You'll get an alert. You'll be questioned as to why it's prescribed, and you'll be calling the doctor. Why are we giving both of these? You'll have extra interventions to do if your patient is being prescribed both of those. Okay. So now you've got your hypnotics that are benzos. These are old school hypnotics. We do not use these very often out in the real world anymore. These are pretty old school. They're dangerous. Again, they end in PAMs and LAMs. Okay. They take about 30 minutes to 45 minutes to kick in and start working. They're addictive again. Addictive, addictive, addictive. Person's going to have a hangover in the morning. They really hit hard on the CNS system. They're going to impair motor reflexes. Oh my God, do they impair motor reflexes? They're going to create ataxia. Ataxia is different than an unsteady gait. Think of it as a DUI walk, okay? Where you want that heel to toe and walk the straight line. But this person isn't going to heel to toe. There's no way they can heel to toe. They are going to look like they're climbing a mountain. They're going to lift their leg really high and they're going to fall over to the side. It is a very, and you can actually type this word in on YouTube and have somebody show you an ataxic walk. And you're going to want to run and try to catch them because of the way they're walking. That scares the heebie-jeebers out of you when they go trying to walk. So very old school. They're just not something we want to use very often with a person or prescribe to them. Now the Z hypnotics are the ones that we see still being used. Not as often, but we still see them. Lunesta has the longest half-life, I would say, because it works for 7 to 8 hours, but Ambien, Sonata are out there. Notice they're called the Z hypnotics because they have the letter Z in their generic name. Okay, that will help you recognize them. And they do not have the anti-anxiety agent in them, so they don't have the muscle relaxant effect, and they just are selective on the GABA receptors. Now with these, you guys, the Z hypnotics, the person needs to be physically in their bed when they take them, because they kick in within 15 minutes, and so they literally need to be in their bed in order for it to kick in to work, or otherwise pretty much what will happen is they won't be there for it to work, and then they can't fall asleep. So that's kind of how it becomes a problem. And typically with Ambien, Sonata, they usually will work for anywhere from 4 to 6 hours to keep the person asleep. And we don't see the leftovers of staying asleep at night. But sometimes, like when a person has pain issues, etc., sleep aids are pretty good with kicking in the Z hypnotics with getting them to sleep and helping them stay asleep through the night. Okay, then we have SNDIs, serotonin norepinephrine disinhibitors. Okay, so now we're going to have norepinephrine and dopamine reuptake inhibitors with the nicotine and acetylcholine. So it's a really big, huge combo here that we're kicking in and using. So insomnia, tremors, anorexia, and weight loss. This is huge. On top of this is getting into basically, and this is the drug I was talking about, bupropion. This is the other drug that people mix up with the buspirone. So this is the one the anti-anxiety I was talking about. This is the other drug. So this is why I wanted to speak to it. So with this drug here, this is the antidepressant. So this one causes insomnia, tremors, anorexia. Unless it is in an extend release, you do not want to give this drug late in the day. And it's used to treat smoking cessation. It's used to help people with weight loss as well as for depression. But it's the one thing you do not want to do. You do not ever want to give this to a person who has an eating disorder or a seizure disorder. This drug all on its own is a drug that you do not want to give to somebody who has, what's the word I want to use? Any kind of seizure issue or eating disorder, because of the fact that it puts them at risk to have a seizure. Even if you do not have a seizure disorder, it's going to increase your risk to have a seizure. It lowers your seizure threshold. Yes, it lowers anybody who takes this drug, it lowers your seizure threshold. So that means, say you're on this medicine and you got a minor concussion in an auto accident. You need to immediately be taken off this drug because you are at great risk to have a seizure. And you need to not ever be put back on this drug again, because there's a good likelihood you're going to have a seizure. Even though you've never had one before, you're potentially going to have one. Even though you just have a minor concussion, there's a good chance you're going to have a seizure. And that's usually the test question that's going to happen, is surrounding this, whether it's on a HESI or a board question or an exam question. It's usually around seizure issues, recognizing that that's what's happening and taking place, and recognizing that it's from the patient's history that they are taking Wellbutrin or bupropion. Okay, so that's the big deal with this. Okay, then the last drug on here, Remeron. This is the Houghton drug. It's an old school drug. The VA hospital, the VA drugs, this is what gets used a lot. It's a great antidepressant. It is old school. It has no sexual dysfunction issues whatsoever as an antidepressant. But it does cause weight gain. It does cause sedation. At a low dose, it causes lots of sedation. So 15 milligrams, it's going to knock a 6'5", 300-pound man right on his butt. But as 60 milligrams, wide awake, up and functioning, not a problem. It also is a great antiemetic, so if you're super nauseated, it works really great and stops that nausea. It also has anti-anxiety effects as well as an antidepressant effects. But it's used a lot by the VA hospitals, and it's great for people who do have some a lot of trauma issues. It will help with sleep, but it does cause a lot of drowsiness, and so we have to be super careful with things and be on top of things. Old school drug. Okay, so our next group, melatonin. Now, melatonin, as you know, is a natural sleep aid. And again, don't forget to look at your HESI book. Look under the culture component and look at the herbal remedies for all these other things, for anxiety, for depression, the St. John's wort. But melatonin is used for sleep. And when we look at the melatonin component, pay attention to this, because one of the things that happens with melatonin, and people don't realize this, is it causes sexual dysfunction because it increases prolactin levels. And if you increase prolactin levels too high, you end up developing gynecomastia. And it causes females to have lactation issues. And people don't understand and realize that this causes a whole mess of difficulties for people. So even though it is natural, it has to be regulated. And a lot of melatonin isn't regulated through any FDA components. And so we have to stay on top and watch. The other two are histamine blockade type elements. The last one on here is what we call buspirone, or otherwise known as Buspar. Now I want you to pay attention. You get on a bus to have pie. And I know that that sounds funny. Get on a bus to have pie. And this is page 50. And the reason I'm pointing this out to you is because there's a look-alike, sound-alike word of an antidepressant, that buspirone, or I'll come up with it later. But right now I want you to get on a bus to have pie. Buspirone, okay, is another anti-anxiety medication, okay? Anti-anxiety medication. I put it at the end here, and I want you to pay attention because it reduces anxiety without having any strong sedation. It actually can cause insomnia unless you get it as an extended release. So you want to take it during the daytime versus at bedtime unless it is an extended release drug. And the reason, because it can cause insomnia, and it is because it has serotonin in it along with anxiety, and it also has an affinity for dopamine, and dopamine can keep you awake. So between serotonin and some dopamine, you don't want to go to sleep, okay? So with that, before I continue into the antidepressants, just to finish on that buspirone, I want you to make sure that you understand it's still somewhat of a short acting, but with buspirone, it doesn't kick in and work right away. It takes 2 weeks for it to start working. Buspirone takes 2 weeks to start working, and a lot of patients will complain that my medicine's not working, my medicine's not working. Yes, because it takes 2 weeks to start working. So sometimes they'll give them a little bit of benzodiazepine to take for a couple weeks while that one starts to work, okay? But once it does, it will kick in and start working. But again, this one will give it for maybe 3 months to 9 months for them to take, and see it that will work and help them to deal with their anxiety. But when somebody has long-term anxiety issues, a lot of times what will happen is we will move them into taking antidepressants instead of taking anti-anxiety medications, when anxiety disorders can overlap into depressive issues, okay? So we then sometimes start looking at taking SSRIs, okay, for social anxiety, generalized anxiety disorders, panic disorders, post-traumatic stress disorders. So we have different ones that can be used out there for a patient. So effexors can be used, is one of them. Let's see, Cymbalta can get used. So there's a few out there that can be used for different types of disorders that exist. So antidepressants can be used for more than just depressive issues, okay? So that's what we're going to get into now. So I want you guys to go ahead and step out and take a break for a minute and pause me and stretch your legs, and then we're going to get into antidepressants. All right, so here we go. So we have different types of groups of antidepressants. We have what was first created, the MAOIs. Then we had the tricyclics. Then came out the SSRIs, the SNRIs, the SNDIs. And so there are some specific dietary and drug restrictions that we need to know. You've got to memorize, especially specifically for the MAOIs. You've got to know these. You've got to memorize these. And then there's also some things you might need to incorporate with med teaching plans regarding herbal treatments, okay? So we're going to get into those. So, page 51, figure 3.21. So, one of the things that's very helpful, especially for those that work really well on pictures, okay? This is all your antidepressants, and they show you your histamines and your side effects and what they cause. So, for example, your serotonin reuptake inhibitor reduces depression, anxiety effects, GI disturbances, sexual dysfunction. Your norepinephrine reuptake inhibitor reduces depression, tremors are caused, tachycardia, erectile ejaculation dysfunctions. Your Infinity 1 blockade, which is what? Do you guys remember what that particular one is? Again, that is your norepinephrine, right? It's just as being said in a different way. It's posterior hypotension, because your norepinephrine has different stages, okay, of a 1, a 2, and then it has it has different elements. It's broken into different segments, okay? But posterior hypertension, dizziness, reflex tachycardia, memory dysfunction. Your norepinephrine 2 block causes priapism, which is prolonged what? Prolonged do you remember? A male's penis has a prolonged erection. And if it doesn't go down, it requires immediate medical attention, because we need to get the blood flow out in order for it to relax. Then you have your acetylcholine block, blurred vision, dry mouth, constipation, sinus tachycardia, urinary retention. So I can go on, but what you're going to need to know is which group, especially which group of our antidepressants is causing primarily which side effects, so that you've got this down to be able to teach your patient what side effects to report, which to expect, how to treat. And so this is where this is coming from and how to deal with this. H1, histamine, sedation, drowsiness, hypotension, weight gain. H1, weight gain. And you're going to have some patients who are going to be non-compliant because we don't want to gain weight. So these are some big issues that our patients are going to be contending with. So I'm going to start with the drugs we're going to prescribe first. So we're going to start with the newer ones and working our way backwards and explaining why. So selective serotonin reuptake inhibitors, SSRIs. So fluoxetine, Zoloft, Paxil, Celexa, Lexapro, Luvox. Okay, so when we're looking at all of these, what it's going to do is we're going to inhibit the degrading of the serotonin, and we're going to work on the reuptake. Okay, so we're going to block the degrading and we're going to allow for the reuptake to happen. And so while this is happening, it's going to cause some side effects, okay? Some big side effects. So one of the big side effects that happens is it's going to inhibit the spinal reflexes for orgasms. And it's going to end up stimulating different serotonin receptors. And we've got a lot of serotonin receptors in our stomach, in our brain, in a whole mess of areas, which is going to cause nausea and vomiting. Our hypothalamus is one of those areas. And so it stimulates nausea and vomiting. It's also going to decrease dopamine, resulting in apathy and low libido for our patients. And so because of this, a lot of our patients or their spouses who value sex are not going to necessarily want this particular drug. But then if you aren't happy and you want to be dead, this drug may need to happen, because if you're going to be dead, sex isn't going to matter anyway, is it? So you have to look at the lesser of the two evils. Now, if you see a letter like F and S, this is referring to fluoxetine and sertraline, okay? And that's what this means. And so patients that have anorexia and anti-bulimic effects, you do not want to have them on those two drugs, okay? Because of the fact that we don't want to have them feeling nauseated and having them vomit, because we don't want to reinforce anorexic and bulimic behaviors, and it will. Okay, so we have the paroxetine. So these drugs have the Paxil drug there has the most anticholinergic effects of all the SSRIs. That's what that means. And so even though there's an anticholinergic effects with all these drugs, Paxil happens to have the most, and it causes narrow angle glaucoma issues, and so it's just not a good drug of choice for them. So that's what this is all about. So again, with these drugs, it takes 2 to 4 weeks to kick in, and we do not want to prescribe them for this, for that particular piece. The other big issue with antidepressant drugs, and it's for all the antidepressant drugs because they're a serotonin drug, adolescents and young adults, there's a black box warning. The black box warning for these drugs has to do with the fact that they cause suicidal thinking. Yeah, so a drug that's supposed to help relieve depression can cause suicidal thinking or increase suicidal thinking. So because of this, we need to make sure that if they start to think or have increased suicidal thinking, they need to report it right away. So make sure you go to chapter 14 and look over the patient family education on antidepressants on chapter 14. Page 242 is where that chapter starts, and look over what other patient family teaching you would want to do regarding antidepressants. Okay, you need to take the medication regularly. You need to not be stopping and starting it. You would probably want to make sure that the patient is, what else would you want to do for their medication? Probably one of the things I would discuss with them would be discussing serotonin syndrome. What would be some of the serotonin syndrome components that I would want to talk about with them? Serotonin syndrome would be having, like if you miss a drug, for example, if it's in the same day, go ahead and take it. But if it's later in the day, because it's a serotonin, you don't want to take it late in the day. Why would I not want to take it later in the day? Is because they would be up all night. Unless it's an extend release drug. Now there are a couple drugs that they could take at night, and it won't cause them to stay late. So you have to pay attention. So like, for example, Effexor can be taken at night. Sometimes Zoloft can be. So you have to pay attention to the person's ability to sleep. But Prozac usually you don't take not till after 1 o'clock. Other things, sometimes taking with food helps with the medication and decreases the nausea and feeling sick. Let's see, what else would be careful and smart to do. Let's see. If you get a rash, you need to report it right away. Okay, let's see what else. Tell them about their sex drive issues. Avoid taking with alcohol, right? Let's see. Can cause insomnia, anxiety, and nervousness. Inform the provider. Tell them if you're going to be taking any digoxin or warfarin, because those things need to be talked about and discussed. Let's see. We don't mix these drugs with any MAOIs. Of course, you want to always discuss, they can have diarrhea because, again, the serotonin in the GI tract. Dry mouth is very common. Some side effects should be worn off. They're going to, of course, have liver and renal tests, checking their blood counts periodically to make sure everything's all going to be good. Let's see, what else do we want to make sure we're going to do? Oh, and then the serotonin syndrome. I'm going to hold off on talking about that because I have a whole slide for that. Okay. But again, this is first drug of choice that we're going to do. Then we have our SNRIs. These are norepinephrine reuptake inhibitors, SNRIs. So Effexor, Pristiq, Cymbalta. So this means they're going to have serotonin and norepinephrine. So norepinephrine now. So we're bringing on some bigger guns. So when we're bringing on two, now we're attacking two neurotransmitters instead of just one, now two. Okay, so this person's pretty sick. We're attacking two. They're majorly depressed at the same time. So norepinephrine. So we're really engaging that sympathetic nervous system. So if they have hypertension already, this is not the drug to use because we're hitting norepinephrine. And it's already going to put them now, we're going to put them at potential risk of having and then causing them to have hypertension. So if they have hypertension already, this is not a drug of choice. Okay? We cannot do that. So with this, we need to observe and watch and monitor their blood pressure. This has to be watched. This is also going to increase their heart rate. So we have to be monitoring. This is a person that's going to have to come in and be monitored at each doctor's office visit for changes in their heart rate and their blood pressure. Cymbalta. One of the things with Cymbalta is this also can be used for neuroleptic pain. So diabetic neuropathy, and also with fibromyalgia, this can be used. So that's excellent and good for being able to use this. Okay. Then we have drugs that we're going to talk about are the tricyclic drugs. Tricyclic drugs are the biggest anticholinergic drugs that we've got. When I say anticholinergic drugs, I really mean anticholinergic drugs. Nortriptyline, amitriptyline, impramine, they are really out there. They work really heavy. These drugs are really going to be at great risk of causing us huge issues for death. Not just because of the anticholinergic effect, but because these drugs can cause fatal cardiac conduction disturbances due to excessive sodium channel blocking. So what happens is it only takes 5 to 7 pills to overdose. On our SSRI pills, etc., you know, patients are given scripts of 30 pills at a time because the risk for suicide is there. But it usually takes the 30 pills before the person, 15 to 30 pills to overdose. And most of the time we're able to hopefully pull them out. With tricyclics, 5 to 7 pills. That's all it takes. Because between the muscarinic effects of this, or the acetylcholine effects, and the fatal cardiac conduction, together, the person will most likely pass away and die. So you do need somebody to really kind of keep an eye on them with their medications. These are very sedating, lots of histamine effects, so they're going to be sedated, drowsy. They're going to end up having blood pressure, orthostatic issues with these drugs. They're going to need to take them at bedtime. They're usually not a drug that we take a lot during the day. They're usually taken at bedtime, but some are taken also during the day. It depends on, we start at bedtime and work our way around, and we work our way up. So with this being said, they'll cause the anticholinergic effects, which is dry mouth, of course, and almost all of our muscarinic effects of dry mouth happens with all these drugs. But the blurred visions will happen, the tachycardia, the urinary retention, the constipation. And what of these effects are going to be the biggest of the issues, you guys? What are the biggest of these issues? What are the highest priority, life-threatening that you've got to call the doctor about? The tachycardia and the urinary retention. The tachycardia and the urinary retention. Those two are life-threatening. Now, urinary retention, it'll start with hesitation and then go to urinary retention. That means the kidneys are shutting down. That means then we're going to be having that imbalance of the cardiac system trying to take over. We're going into shutdown. The body is shutting down. We're going to die. Tachycardia is happening because they're drying out, and we're going into a heart attack. If the anticholinergic effects happening, and we're in the tachycardia, we're drying out. The body's not going to withstand much longer. So when anticholinergic says tachycardia is just sometimes tachycardia, but when it's anticholinergic effects taking place, that means they're drying out. We have to intervene. We're going to have to get IVs on board, or the person's not going to make it. And if they're drying out and they're tachy, and then they've overdosed, and we've got the cardiac conduction disturbances going on, that means we've got some VTACs going on. This person's not going to be with us much longer. Okay? So far everybody's following? So what are we going to be teaching our person with tricyclics? What would we be teaching them? It may take 7 to 28 days and possibly 6 to 8 weeks for their mood to elevate. We need to reinforce that with their family members, that they're going to be dizzy, drowsy, have hypotension issues the first few weeks. No driving, no operating motor vehicles, careful crossing streets. Their reflexes are going to be slowed. They're going to be drowsy. No drinking alcohol, right? Take their full dose at bedtime. And careful during if they're taking the dose in the daytime, it's going to be a half a dose or smaller dose during the daytime. That's based on what their doctor prescribes. And they should never suddenly just stop taking their medication. This is probably one of the things I didn't talk about very much, but on any of these medications, if they suddenly just stop it, they're going to all have withdrawal symptoms, and they're going to end up feeling nauseated. They're going to have this altered heartbeat. They'll have nightmares, cold sweats, and they're going to feel like crap. And so they'll need to call us. We're going to tell them, take one pill and then come on in, because we need to take and put them and titrate them off their medications. Yeah, a lot of people don't know to do that. Then our next medication is the MAOIs. The MAOIs were the very first drugs that came out. Okay. The isocarbonides are otherwise known as Marplan, or the Nardel, or the Ensom, and the Parnate. The good thing is we've got patches now. Thank you. Which helps slow down the worst side effect of all, their death. It's an organic compound, you guys. They're of these neurotransmitters: norepinephrine, epinephrine, dopamine, serotonin. Epinephrine, norepinephrine, dopamine, serotonin. They're found in food and drink. Yeah. The MAOIs prevent the destructions of monoamines by inhibiting them. And they're used by the liver. And if the liver can't break it down, they become toxic. Monoamines and triamines can't be ingested. Monoamines and triamines. Okay? Because that's what these are all part of. And these are in aged cheese, pickled smoke, fish, wine, decongestants. These are just nice, normal, little everyday things. Yes, nice and normal everyday things that we've got. And you're going, what, woman? What are you talking about? Yeah, these are nice, just everyday things. But you can't ingest monoamines and triamines, because if you do, you're going to have vasoconstriction. And if you vasoconstrict every blood vessel in your body, you're going to create a hypertensive crisis. And something's going to go pop goes the weasel in your body, and you're going to end up dying. Because your body can only take so much pressure, and you'll die. You can't live through it. So what does that mean? So, decongestants, cough syrups, any kind of decongestant. So what is that? What are those decongestants that are out there? Robitussin's. I can't even think of all those. Sudafeds. Think of all the ones, all the cold medicines that are out there. You can't take them when you're taking these medications. Think about how many times you get the flu and you take over-the-counter drugs. You just cannot do it. Foods. Page 262. Avocados that are very ripe. Soybeans that are fermented, the paste. Figs that are overripe. Bananas that are overripe. You can have regular bananas, just not when they're overripe. Meats that are smoked, fermented, pickled. Bolognas, pepperonis, salamis, things that are sausaged. Fish that are pickled and cured and smoked. Let's see, what of foods that are have a lot of yeast in them. Wines that are not that are high. Let's see what else. Beers. A lot of imported beers are not good. Okay. Chocolates. Especially their dark chocolates. Faba beans, ginseng, caffeinated beverages that are heavy caffeinated beverages. Okay. You just got to be very, very careful about it. So you just have to be super, super careful. There's several narcotics you've got to be very careful with that have monoamines in them. Tricyclics, of course, you got to be avoidant of. Any serotonin drugs you've got to be avoidant of. So those stimulants like amphetamines, cocaine, excuse me, I should be very clear on that, cocaine, you have to avoid. Okay, alcohol, benzos, sedatives you got to avoid. So those levodopa you got to avoid. So those are just some of the many things. Some antihypertensives you have to avoid. So there's just a lot that are out there that you got to do, and you got to teach your patients to be very careful with. And that's where a lot of your patient teaching is all around and all about. Then you've got a couple other antidepressants. Vibrid is one of them. Side effects biggie for their diarrhea, nausea, insomnia, vomiting. And it's always better to take with food. And then you've got your trazodone or Deseril, and just sedation, orthostatic hypotension, and just pay attention that it blocks histamine, and papyrism, prolonged painful erection. That's the biggie for men. You just got to teach. And boy, let me tell you, when I was a new grad out of school, that was probably one of the biggest issues that was not taught to me. And that ended up being a big issue that was a hot commodity for me that I did not know about. And I was, of course, working on a kids unit, so that was not an issue because this was not a drug that we provided to kids. But I got called over to help a nurse on the adult unit and had to go over, and she's like, it was like 2 o'clock in the morning, and I had to stay over because I had the nurse not show up for the night shift. And she's like, I don't know what to do, and I don't know what his issue is, and she was uncomfortable talking to him. And I was like I am any better? I'm like 24 years old at the time. And so I was like, okay, I'll go down and talk with him. And he's filling me in what's going on. And I was like, how many hours has this been going on? And it had been going on for like over, oh my God, 6 hours already. And I was like, holy crap. So needless to say, I got him over to the emergency room, and, it was his medication that had caused this. And she was uncomfortable to even have a conversation with him about his penis being erected. And the poor guy was in pain. You have to, as a nurse, get past your own discomfort when somebody is in pain, you guys. You have to. And just be able to have those conversations. This isn't about you. It's about your patient. And, and so those are those kind of things. Take them out of their room, go into the exam room, be the nurse. Okay? This isn't about you. So keep those things in mind, and no matter how young, how old you are, you're the nurse. And think about that, and think about your patients. So, serotonin syndrome. So, what happens when you get too much serotonin in your system? You really need to be conscious about this, because all you can think about sometimes is your patients being a pain in the tuchus. Okay? Because they'll start showing being restless, hyperactive, and irritable. That's what you first start to see. Not realizing what's going on. And they'll complain to you that they have some abdominal pain, irritability, and they're gassy. So, gassy, abdominal pain, irritability, restless is what you start to see. That's what starts first. Then you start to think, oh, maybe I should check vitals. Do it right away. Because what you're going to see is their blood pressure's up a little bit, their temp, they start to get a little bit of a temperature. They're a little tacky, not much at first. It keeps going up. They start to have, and they'll have diarrhea. They start to get a little bit more irrational, and their mood swings start happening even more. And everything starts to elevate up, and they start to have altered mental status, getting a little more delirious, and more irritable, more hyper, until they are really in trouble. And they start having muscle rigidity. They start to potentially have seizures, and they start to have seizures where really you miss the signs. The fever's the dead giveaway. The fever is always the giveaway. And this is where I get on top of my texts, because they don't understand in the land of psych. Because remember, this is all CNS. CNS. Our fever, our temperature is one of our biggest warning signs that there is a medication problem. They're having a side effect to their medication is the fever. Yeah, the fever, you guys, their temp, because they can't regulate. So the first thing we do is we hold their meds. We call the doc, and we're going to start, most of the time when this happens in freestanding psych facilities, we've got to get them sent over, because we don't do a lot of tubes. We're going to end up needing to get an IV started, as we're going to start needing to put in fluids. We're going to start loading and onboarding meds, IV. Going to start putting cooling blankets on. We're going to start putting Dantrol in and some diazepam to start trying to bring the temp down and get the muscle rigidity pulled together. Anticonvulsants on board. There's a good possibility if you don't get in soon enough, you might have to start artificially ventilating the person, and sometimes you have to induce paralysis. Yeah, it can get pretty bad pretty quick, and we may have to blockade some of the serotonin. We block the serotonin receptors with some meds in order to stop the continuing absorption of the serotonin in the brain. So yeah, it can be quite serious very quick, because again, these medications continue to be absorbed through in that brain for a period of time, and we have to look and recognize as fast as we can to stop that serotonin syndrome. Okay, so I want you to take a break, and then we're going to move into the mood stabilizers. So now we're into the mood stabilizers. This is what we use mood stabilizers for our bipolar patients. Now our bipolar chapter is chapter 13, page 222. So with that particular chapter, I want you to look at the patient teaching for that. And we'll get into more components with this, and the biggest with the patient teaching with this has a lot to do with lithium. Lithium is our biggest one you need to understand. So with mood stabilizers, we're talking about the fact that patients can go from a depressed state to a manic hyper grandiose state. So we can go from very low to very high, and the mood goes up and down, up and down. And so we need to stabilize this mood. Okay. So, and we'll get into understanding all of those components, but with this, page 55 is the biggest piece here for chapter 3. So with lithium, lithium is an ion. It's a salt. It's similar to sodium, okay, and potassium. And so it affects the electrical conductivity of your neurons, okay? So it's a salt. So your salt and potassium needs to stay in balance. It's one of the most important things you have to remember is think of it as a salt. So knowing that, you need to understand that you have certain tests that you need to make sure are in balance before you can start this drug. You need to check the BUN and the creatinine levels because you need to know your kidney is functioning absolutely perfectly. Kidneys have to function perfect. If your kidneys do not function perfect, you cannot take this drug. Because if the kidneys aren't working okay, then you aren't going to be able to take it. It's that simple. You still have to check your electrolytes. You still will need to check your liver. You know, everything else still needs to be checked, but your BUN and creatinine have to be checked. And then you will need to continue to check these things at least every 6 months. But you have to get a baseline. If your baseline is not functioning, there's no way it's going to keep working. So then once you've got that checked and everything is good, okay, then we've got some other things to take a look at. So with this, we have to have a level with the lithium. Because once a patient is taking lithium, they're going to be taking this drug. And when they first on the board, they're going to be having a little bit of nausea, some vomiting, some diarrhea, and some polyuria, where they produce too much urine at first. These are just normal side effects that are expected. There's some being lethargic a little sedation, and some fine hand tremor. This is just all normal onboarding of lithium. Okay, this is expected. So that is normal expectation. Also, they have to be taught, oh, and I didn't mention this, we also need to check their thyroid levels when they first start. And that's an important thing to do because one of the things that we know that we have that can happen is long-term effects is we can cause thyroid problems down the road for a person who is taking long-term treatment with lithium. Is thyroid issues. They can develop goiters and hypothyroidism. So you have to make sure the thyroid's normal. Okay? So, with this in mind then, lithium levels have to be checked. So, normal lithium level is anywhere from 0.6 to 1.2. At a 1.5 and higher is when we can start seeing toxicity issues. So what do toxicity issues look like? So at toxicity, we can see coarse hand tremors, confusion, hyper irritability of muscles, sedation, and incoordination. So what does that mean? So instead of fine hand tremors with just some slight shaking, they're much bigger hand tremors. Okay? They're muscle irritability. So it's kind of like having hyper reflexes. On top of that, being super sedated and being incoordinated. So you're dropping things. You're not coordinated. Okay? So what do? You hold the lithium, you get a level. Okay? And if you're having confusion, at that point in time, we're probably actually going to be sending you out to the emergency room at that point, because you're really kind of in trouble at that point in time if you're confused. That's showing us that you're having altered mental status, and that we need a higher level of care of intervention to take place. Okay? Makes sense? Following me so far? You're also going to have, if you have bradycardia, polyuria, edema. Okay? Again, sending you out. So, how do I really tell if this is an early onset of just regular expected side effects or an early onset of toxicity? My question to my patient is, when did you start your medication? I just started it 2 days ago. Or I started it 2 weeks ago. Because it takes anywhere from 7 to 10 days to get a level up. 7 to 10 days. So if it's past 7 days, then I need to worry about it being a toxicity issue. If it's under, then I need to worry about it being just the startup of a drug, and it's not toxicity. It's just starting the medicine. So when you're having this, you need to explain to the patient the difference between starting side effects and toxicity side effects. So let's talk then about this in educating your patient. So since we know that this is a salt and sodium balance, what do you think you need to talk to your patient about regarding diet and fluids? They need to maintain their diet. They need to not suddenly change their diet and their fluid intake. So it's not a time to, oh, I'm going to start a weight loss program, or I'm going to start this or start that. If you eat a bag of chips every day, then you need to keep eating the same bag of chips. Why? Because that's a certain amount of sodium you're putting into your body every day. And changing that sodium amount every day is going to change on how much lithium you're putting into your body every day, because it's going to change your absorption of your lithium. It's sort of like what you guys learned about with greens and warfarin. It's going to do the same thing with your lithium. So I'll give you an example with somebody who's a construction worker that comes down from, who works up north. And during the winter months, they come down to Florida to work construction outdoors. And they're fine. They drink about 1,500 milliliters of water every day. Okay, but it's now they decided, instead of going up north to work in construction, they decided to stay here in Florida to work. And it's 100 degrees outside, and they didn't change their fluid intake, and they're sweating up a storm and still just drinking 1,500s of fluid, and they're outside sweating up a storm, and they're still taking their lithium level the same amount every day, and they're sweating. What's going to happen to their lithium level with them sweating out all that water? That person's going to end up being toxic. And they didn't overdose, but their lithium level got toxic. And it looks like they overdosed on their lithium. So the person has to learn how to adjust their fluid intake to manage their lithium level. So you have to teach about the importance of maintaining a consistent fluid intake and how much that is, and how much to balance their food intake. Okay, you have to teach them about not informing their doctor about any diuretics, because they shouldn't be taking them unless their doctor's fully informed, because that has to be taken care of very careful. How about antacids or antiemetics? Like Tums, for example. Tums, is an antacid. Those are full of calcium and sodium. That will throw lithium levels off and can cause toxicity, because of the calcium will attach to the lithium will attach to the calcium and elevate levels. Also, what we haven't really talked about yet but need to, is we have patients that are bipolar, and when they are in a manic state, do a lot of risky behaviors, such as having unprotected sex. They take a lot of risk behaviors and put them at risk of having STDs. And some STDs are treated with Flagyl, Metrazole. And they'll go to the ER, and the Metrazole gets prescribed for them, and they don't tell the doctor that they are taking lithium. And Metrazole cannot be taken with lithium. It'll automatically kill the person. And the patient is given this drug, and they die. And the person's too ashamed to acknowledge that they've got bipolar disorder. It's bad enough they've got a STD. And so there's a whole mess of shame that's associated. And so there's a lot of things that go on. And that's another drug that interacts in a negative manner with lithium. And these are things we have to teach our patient, so that we can ensure that they are aware and can avoid having a negative effects on our patients. Other medications that treat our patients are anticonvulsant drugs: valproate, Depakine, Depakote, carbazepine, Tegretol, Lamictal, gabapentin, Topamax, Triliptal. So these drugs also are used to treat specifically for mood stabilizing. Okay, they all affect the GABA in helping reduce the mood swings. So, for example, the valproate or the Depakine, Depakote help a person who has mixed episodes. They go from high to low, high to low. The carbazepine specifically helps with mixed or helps with manic episodes. But again, that one can cause Stevens-Johnson syndrome. The Lamictal is very good with maintaining somebody who has bipolar disorder. So once you get them stabilized, that's a good state, keeping them stabilized. And then the other drugs, the gabapentin, the Topamax, the Triliptal, the FDA has not yet approved them, but they are using them to treat a person. So make sure to look over the patient education in chapter 13. So take a break, and then we're going to get into your antipsychotics. So your antipsychotics, we have you're going to want to look at your chapter 12 for your antipsychotics. Okay, for your patient education components there. with these, we have two types of antipsychotics. We've got the first generation and the second generation drugs. First generations can be referred to as conventional or typical, and your second generation drugs are also known as atypical drugs. Now, first generation drugs are old school, okay? That we do not prescribe these first. However, they are our cheapest drugs, but they have the strongest movement disorders, the EPS symptoms, extrapyramidal symptoms, and they are going to cause the most sedation and the most weight gain. Okay? But they're going to cause the most movement disorder issues, and they're going to cause weight gain, and they're going to cause sedation. They have the most histamine issues and the most movement disorder issues. Okay? They bind to the dopamine receptor sites, they block the attachment of dopamine, and they reduce the dopamine transmission. This is why we have the most movement disorder problems. Okay? So far, so good. So, they also have acetylcholine, norepinephrine, histamine, and again, weight gain, sedation, and movement disorders are all part of the issues. These drugs here treat the positive symptoms of schizophrenia, the positive symptoms. That means, or psychosis, which means they treat the hallucinations and the delusions, the hallucinations and the delusions, the positive side effects, hallucinations and delusions. Okay? So Haldol is one of the biggest drugs that is used. Haloperidol, Haldol. The phenothiazines, thorazine, prolixin, stelazine, mellaril, trilofan, compazine. Compazine's also been known to use for an antiemetic. Serotine, Navane, the bupropions, the Haldol, the Moban, the loxapine. Okay, these are all first generations, all old school. Okay, again, a lot of movement disorders we call extrapyramidal symptoms, movement disorders, because of the dopamine. Okay, movement disorders. Okay, can't say this enough. Movement disorders, EPS. So one of the things we teach our patients about this is they tell them, if you notice your body moving without your knowledge or without you moving it, please report it right away. So we got a lot of blood pressure issues, anticholinergic effects, orthostatic hypotension issues, anticholinergic effects, so dry mouth, those kind of things. Let us know. Tell us that these things are going on. Second generation drugs, we have fewer extrapyramidal side effects. It still has dopamine effects, but we also now add in serotonin, okay? And it targets both positive and negative symptoms, but it's now what we choose first to use, okay? We want to use this first. And because it's targeting both positive and negative symptoms, because the serotonin's there, now we're able to treat some of the 5 A's. The alogia, the anhedonia, the evolution, So we're targeting those A's more. So it's not just the hallucinations and the delusions any longer. Okay, so we're picking these, but they cost more. So this is a big issue for some people to be able to afford these. Okay, so the problems though with second generation, okay, is this here represents the big issues with the old school, the first generation, the EPS and the tardive dyskinesia. That's over on your left side of your screen. Okay, on the right side we have more issues with what we call metabolic disorders: weight gain, diabetes, hyperglycemia, insulin resistance, dyslipidemia, cardiovascular disease. Okay, we still have some EPS issues, extrapyramidal issues, and so we still have other issues, as you can see, but we have a lot more metabolic disorder issues with second generation. Okay, so we have to pay attention when we're starting somebody on drugs, because we know down the road we can cause somebody to have diabetes. We know that we can have them have cholesterol issues, or hyperlipidemia is another way of wording that. And we still know that we can cause them to have a movement disorder down the road, or Parkinson's disorders down the road. Okay, it's another way of, okay. Second generation drugs here: clozapine, Zyprexa, Seroquel, Geodon. Want to talk about clozapine, Clozaril, a second. Clozaril is free from motor side effects. Okay, however, it has a very special side effects that none of the other drugs here have. It can cause what we call agranulocytosis. Very different than all the other drugs. This drug suppresses bone marrow. It specifically targets the neutrophils, and it's potentially a fatal side effect. So what needs to happen is the patient that is eligible for this drug has to be somebody who is going to be, has a strong support system, who has the ability to access a lab, who will go weekly to have blood drawn, to have their neutrophils, their ANC count drawn every week for the first 6 months, to test it to make sure that they are in compliance with their neutrophil count, to make sure that they do not have a drop in their count, so that they can continue to take their medication. Yes, every single week, in order to get their medication filled. And then you have to specifically teach this patient that if they have a sore throat, they need to call immediately and come in to have their blood drawn. Because the sore throat is their only warning sign that they are having a crisis. Because they may or may not have a fever. And the sore throat is the only warning sign they have that they are having a crisis, a neutrophil crisis. Because this is like somebody who's like going in for a bone marrow transplant, for example, and you have to put them in reverse isolation, and you have to wipe out their neutrophils so that they can have the bone marrow. And what happens if you wipe them out? They're not going to get a fever, right? And they get an infection. And you don't know it. By the time they get a fever, it's possibly too late to take care of them, right? So this is the only warning sign they'll have is a sore throat. And it could be with or without cold symptoms, with or without a fever. So that sore throat's the only warning sign that's there, and they've got to come in, they get a blood drawn. Once you get past that 6 months, it usually then goes to a monthly draw. But you got to get them through that first 6 months. So that's the most important education thing to do, is to teach them about that sore throat. Other drugs is paliperidone, the isoperidone, the Latuda, Sapphirus. The thing that's nice about the Sapphirus with elderly people that get agitated, especially with sundown syndrome, you can do a little dissolvable little film and put it under their tongue, and before they're done arguing with you about not taking it, it's already dissolved. Which was wonderful. And then, of course, there's Abilify. And with Abilify, one of the things that's great about it is it has the least amount of side effects, which is great. But it can cause akathisia, which is a restlessness. And we'll get into more of those movement disorder issues when we talk about our schizophrenia chapter, and you guys will get to see all of those side effects. Okay, so now we're going to talk about movement disorders caused by our antipsychotic meds a little bit here. These are the meds to treat our movement disorders. Okay, so with this, we use benzotropine, Cogentin, Benadryl, Artane. And then for tardive dyskinesia, which is can be a permanent movement disorder, we use Ingrezza. So, with this being said, the most important thing I want you to remember of these, besides these drug names right now, is that you need to remember the route. If the movement disorder is affecting anything on the neck or the face or the tongue, you cannot give it to them orally. And that means it can only be given by IM or IV. IM or IV. So pay attention to the route when you're choosing the medication, because that will be your giveaway. The other thing with your movement disorder drugs, or not movement disorders, drugs, excuse me, your antipsychotic drugs, is they can cause what's called neural malignant syndrome. Neuroleptic malignant syndrome can be caused by your antipsychotic medications. Basically, it's going to burn up your brain. Temperature, you guys, temperature. It's very similar idea to your serotonin syndrome, except for it's not serotonin that's causing this. You're going to see the same kind of idea. It's rare. It's 2% of the population. You're going to see your muscles start, it's going to look and sound like your movement disorder. The muscles start getting stiff. You're going to see an elevation in blood pressure and pulse at first, hypertension, tachycardia, diaphoresis. The person's going to get incontinent, but it's the temperature starts to go up, and it goes from 0 to 103, 104, 105, very high. They're going to go into a coma and death if you're not moving very quickly and responding. Muscles are going to get rigid. Flexor extender posture, reduced or absent speech. You're going to think that they're getting catatonic on you, but it's not. It's neuromalignant syndrome. You got to act fast, holding the meds, bromocriptine, Pardel, the dantrolene to get that fever in place, the Dantrum to relieve muscle rigidity, cooling blankets, temperatures, IV fluids, electrolytes, and you're going to be treating those dysrhythmias and pray that they're not going to die on you before your interventions kick in. Your ADHD drugs, your Ritalins, your Adderalls, those are your stimulants. Need to understand that these are norepinephrine, these are your dopamines. They're stimulants. They're going to exacerbate antipsychotic thought processes, hypertension. Ritalin affects growth. They're going to cause a person not to grow. It's one of the biggest side effects is growth suppression. Doesn't do it to everybody, but it affects a lot of them. There's huge potential for abuse. You put a kid or an adult at risk for hypertension. Your non-stimulant drugs, the Strattera, the clonidine, even though they are non-stimulant, they increase blood pressure, pulse, they decrease appetite, they cause weight loss. They still have the same effects as a stimulant. They're changing a person. And I'm not necessarily anti-drug, but you have to understand that they have effects. Alzheimer medications. The tyrosine, the conic. We don't use this drug anymore. However, it still shows up sometimes on HESIs and the board exams. We don't use it anymore because it causes hepatic toxicity. It causes hepatic toxicity. We have the Aricept out, the Razidine, and the Exelon. Those are cholinesterase inhibitors. Okay? Cholinesterase inhibitors. Okay? Then the other type of Alzheimer drug that is out there is the namidine drugs, which are glutamate blocking agents. Okay? And so what it does is it helps keep the sheath over the neurons so they're not destroyed. Then we have our detox medications. One of the most important one is B1, the thiamine drug. When anybody is abusing substances, their liver gets damaged. The more the liver is damaged, the more the fat vitamins, B1, D vitamins, B12s, vitamin A, the carotenes, any of those are lost in from your liver. And your B1, you need it for your brain, any of your B vitamins. Your brain starts to develop lesions, you get ammonia in your bloodstream, your waste issues, and it builds in your brain, you get lesions, and you start having encephalopathy issues. And your B1 has to get onboarded heavily very quickly. For alcohol, we use Librium, Ativan, Valium, and Ciroc. These are all benzodiazepines. For alcohol and benzo withdrawals, we use clonidine, phenobarbital, Tegretol. For opiates, we use Suboxone. For barbiturates, we use phenobarbital. These are the drugs that we used for helping someone stay sober. Antabuse, I can't say it right now, I'm too tired, sorry about that. This is for alcohol aversion therapy. You need to look this drug up very heavily. I'm going to ask someone to do a presentation on this. Vivitrol, Campril, is to use once a month. It can be oral and then used once a month for an injectable drug to help you prevent from wanting to obtain cravings for alcohol and some opiates. Methadone, we use methadone we used for heroin, and Suboxone we used for opiates. And then Narcan or naloxone is used to prevent opiate overdose. Herbal medications. Pay attention. Some of the biggest issues we have are the long-term effects of nerve damage, kidney damage, liver damage. You have to know what you're using and the side effects or the adverse chemical reactions if you use with other substances and with conventional medications. So St. John's wort's used for depression, but we have to be careful not to cause serotonin syndrome with mixing with other meds. Ginkgo biloba for memory can cause liver and thyroid cancer or bleeding issues. GABA is used for anxiety or insomnia. It can cause hepatic toxicity. So a patient who has decreased circulating levels of GABA, which health problem is most likely to suggest? If you said anxiety disorder, that is correct. Because GABA plays the role in modulating excitability and anxiety, and decreased levels are associated with anxiety. A nurse prepares to administer a second-generation antipsychotic medication to a patient diagnosed with schizophrenia. Additional monitoring for adverse effects will be most important if a patient has which comorbid health problems. Select all that apply. If you said Parkinson's disease, hyperlipidemia, and diabetes, you are correct. Eleanor is treated with a blank, which helps to slow the destruction of acetylcholine. D, cholinesterase inhibitor, because we're looking at her having Alzheimer's, right? Which neuroimaging technique would reveal a problem with anatomical structure of the brain but not the functioning? That's right, you guys. A, CAT scan.